Hospital, and he is going to talk to us about iron deficiency in heart failure, Dr. Hussein. So we'll move to that talk and then we'll conclude our session.
Thank you, Dr. Zubaidi, for the introduction, and I really enjoyed the previous session of the ECG. I mean, these are things that can change the practice and can save lives. So in the coming 20-30 minutes, I'll be discussing a bit different topic, which is heart failure and iron deficiency in heart failure. And you all know that heart failure is a very prevalent condition, more than 60 million worldwide. And heart failure is likely to affect roughly between 1 and 2% of the population. This is a big proportion. The majority would have a reduced ejection fraction. Roughly 1/3 would have a preserved ejection fraction. It's the leading cause of hospitalization. The mortality is worse than many of the cancers that we know. And today we'll be talking about iron deficiency and anemia in heart failure. And I will go through these sequence. Are we talking about iron or anemia? What's ferritin? What's transferrin? What's the prevalence of iron deficiency and anemia in heart failure? What's the impact of this deficiency on heart failure outcomes? What are the available therapies, and what is the impact of these available therapies on the heart failure endpoints? And based on that, what do the guidelines recommend in this very particular situation, iron deficiency and anemia in heart failure? So first, what are we talking about? Is it anemia or iron? Is it the hemoglobin or the serum iron level or the ferritin or the transferrin? So we need to go back slightly into the physiology, and compared to what I studied in medical school, now the physiology is much more advanced. This is what we know from the medical school, that iron is one of the most commonly available elements in our body. Our ability of our bodies to synthesize iron is limited. So we entirely depend on the GI absorption. Our ability to excrete iron is also limited. So the serum iron levels are regulated mostly in the GIT. And whenever we have excess iron, then our absorption is reduced. When we have reduced iron, then our absorption is utilized, is increased. And the most important function of iron is at the mitochondria, where it is essential in the oxidative processes, in the Krebs cycle, in the respiratory chain. And so it's the basics of aerobic metabolism. And we understand that when iron is deficient at the cellular level, then the oxidative processes are deficient. So what's iron deficiency? This is adopted from a definition from international opinion on chronic inflammatory conditions, and heart failure is one of these conditions. So iron deficiency, it's either when iron availability is insufficient to meet the body needs, and can be absolute or relative, and we'll talk about that. But one of the important messages that I'll keep repeating is that iron deficiency can be present with anemia or without anemia. So we can have iron deficiency anemia, and we can have iron deficiency without anemia. So it's not the hemoglobin, and we'll keep focusing on that. And a quick overview of what do we measure by the iron indices. We measure basically 3 or 4 variables. The first one is the serum ferritin levels. And ferritin is the storage form of iron in the cells. And it's also available in the circulation. And we can measure that. It gives us an idea about the iron stores, which is the ferritin. The other 2 variables are the serum iron and the transferrin. Transferrin is the protein that carries iron in the circulation. And based on the transferrin levels and the transferrin saturation and the iron binding capacity, we have an idea of the circulating iron. And so we will have 2 conditions that are associated with deficiency or iron deficiency: inflammatory anemia and iron deficiency anemia. In inflammatory anemia, ferritin is high because it is trapped in the macrophages, where the serum iron in both conditions will be low and the transferrin saturation will be low. So we have an absolute iron deficiency where iron stores are deficient. And we diagnose that with serum ferritin less than 100. And we have relative iron deficiency where the iron stores are normal, but iron is taken by the reticuloendothelial system because of inflammatory conditions, and it still doesn't reach the target cells. We diagnose that by some elevation of the ferritin, but more importantly, transferrin saturation less than 20. So these are the three numbers that I need you to recall. Ferritin less than 100, that's absolute iron deficiency, or ferritin between 100 and 300 with a transferrin saturation less than 20. And which one happens in heart failure? Actually, both conditions are happening. And absolute iron deficiency is more common. We see absolute iron deficiency in heart failure because of GIT blood loss, because our patients are taking antiplatelets, anticoagulants, non-steroidal. The mucosal integrity is impaired in heart failure because of GI edema. So there's also malabsorption, which is accentuated by proton pump inhibitors. Patients with heart failure are malnourished. We see them cachectic. They lose appetite. So there's a strong tendency for absolute iron deficiency. But we also have relative iron deficiency because heart failure is an inflammatory condition. There is increase in cytokines, interleukins, tumor necrosis factor. Many molecular interactions result in relative iron deficiency, which is again ferritin 100 to 300 with transferrin saturation less than 20. So in heart failure, we have the absolute deficiency and the relative deficiency. But the problem here is with ferritin. As there is an inflammatory condition, ferritin levels tend to be high, whereas with absolute iron deficiency, ferritin levels tend to be low. So we tend to correct that by measuring the transferrin saturation and the serum iron. How prevalent heart failure, iron deficiency is in heart failure? In chronic heart failure, more than half of the patients have a form of iron deficiency. Whereas in acute heart failure, it's even more common. 80% of patients with acute heart failure will have iron deficiency. And it's seen even more with heart failure and preserved ejection fraction. So it has no relation with the ejection fraction. We see it in reduced ejection fraction, and we see it in preserved ejection fraction. So what's the impact of iron deficiency on the outcomes of heart failure? As we lose iron, either absolutely or relatively, we see that the peak oxygen consumption, which is an expression of the exercise capacity, tends to be reduced. And we know from both curves that anemia on its own is less correlating with the poor functional class than with iron deficiency. So if we have anemia and no iron deficiency, then the functional class is better than having iron deficiency with no anemia. That's why we'll see the guidelines, they recommend screening not just with hemoglobin, but again with the iron indices, with the ferritin and the transferrin saturation, because it's not the matter of anemia, it's the matter of iron deficiency. Of course, if there is anemia with iron deficiency, then things will be much worse. So again, having anemia alone with having no anemia, but with iron deficiency, it's worse, much worse than having iron deficiency with no anemia. And of course, having both combinations, having both together is the worst thing to have. And this has been reiterated in more than one study and more than one cohort. Having iron deficiency is more predictive than having anemia. And having both is, of course, worse. And these are the curves that where we got the cutoffs. And the transferrin saturation less than 20 is associated with an increase in mortality. Serum iron also is a variable that you can keep in mind. And as the serum iron goes below 15, then again, the mortality tends to increase. And in fact, there has been a recent study that's published just a few days ago that shows that serum iron may be more predictive and more associated with mortality than the other two variables, the ferritin and the transferrin. And the serum iron less than 10 is associated with the worst prognosis. So if we replace iron, so we know that iron deficiency is bad in heart failure, correlates with mortality and with poor functional outcome. If we replace the iron, can we improve the heart failure outcomes? And iron replacement has been a field of several studies, a dozen studies, early since 2003 up till 2020, and there are more studies to come. The latest study is the AFFIRM study recently published in November 2020. And there are also ongoing trials on heart failure with preserved ejection fraction, looking at the hospitalization and the mortality and the change in functional class. So I've chosen just a few of these trials to highlight what's the effect of iron replacement therapies on heart failure outcome. The first trial, the most important one, was in 2009. And it tested the most tested iron preparation, which is ferric carboxymaltose, in patients with heart failure and iron deficiency, randomized to ferric carboxymaltose or placebo. And this was a trial that focused on the functional class. And we see that with parenteral iron, all the functional class scores improved in the ferric carboxymaltose group versus placebo. So if the idea of iron replacement seems to work, at least to improve the functional class, why do we have to go through the hassle of injection? Why not oral replacement? But in fact, it failed. In the iron out heart failure randomized trial published in 2017, high-dose oral iron did not improve the oxygen consumption, which is an expression of the functional class, in patients with iron deficiency and reduced ejection fraction. And so iron replacement by the oral route is not the way to go. It doesn't work. Again, going to ferric carboxymaltose, where we have the biggest evidence and the biggest efficacy. Another trial, which was the confirmed heart failure trial published in 2015, showed not only an improvement in functional class and the fatigue and the questionnaires and the 6-minute walk test, but this was the first time to show that iron replacement was able to reduce recurrent hospitalizations. And this is one of the most important endpoints in heart failure. We're having therapies in heart failure, like, let's say, vericiguat, which the benefit is only in reduction of hospitalization. So if we have a simple agent that we can give in the outpatient that has the ability to improve heart failure hospitalizations, then this is something that we should pursue. In another trial, and this is a meta-analysis showing the effects of ferric carboxymaltose from several trials, it improved not only the functional class, it improved the combined endpoint of hospitalizations and all-cause mortality. So believe it or not, you have a simple replacement, a single shot that you can give the patient, and it improves hospitalizations and mortality combined. Another trial, the effect, published in 2017, showed improvement in functional class, oxygen consumption, and the global assessment scores. And probably the latest one among these is the AFFIRM acute heart failure, published in the Lancet 3 months ago. They were looking at patients who were hospitalized with acute heart failure, not just chronic heart failure. And what they did after discharge of these patients with acute heart failure, they randomized them to injection of ferric carboxymaltose versus placebo. And we can talk about the dose. They included patients who have iron deficiency based on the criteria that we said, ferritin less than 100 or ferritin between 100 and 300 with transferrin saturation reduction. And they looked at the composite endpoints of total heart failure hospitalizations and cardiovascular death. And they also looked at the functional class and other variables. Again, these criteria that we need to remember, ferritin less than 100 or ferritin with transferrin saturation less than 20. Of course, they excluded patients with hemoglobin less than 8 because these are the patients who need packed RBCs transfusion. Parenteral iron alone will not work. So in the first week, they were given 1 gram of ferric carboxymaltose if the hemoglobin was less than 14. And if the hemoglobin was more than 14, they still gave them, of course, because we're talking here about iron deficiency. We're not talking about anemia, but the dose was less. And then at 6 weeks, if the hemoglobin was still low, it depends on the body weight. It's either 500 or 1000 milligram. If the hemoglobin is between 10 and 14 and less than 70 kilogram, you don't need to give them anything. So it's just one shot that's sufficient for the patient in some instances. If the patient is above 70 kilograms, then 500 milligrams would be enough. At 3 to 4 months, only if iron deficiency persisted, then they were given another shot of 500 milligrams. And one of the nice things I like about this therapy is that you can give only 1 or 2 doses and you improve the outcome of the patient. 80% of patients required only 1 or 2 doses, and 20% required 3 or 4 doses. And looking at the safety, there were no difference in serious adverse events with ferric carboxymaltose injection versus placebo. Nothing of diarrhea, of infections, of reactions. There were no difference from placebo. And of course, looking at the laboratory parameters, once we give the shot in 6 weeks, we see a dramatic change in ferritin compared to placebo, where placebo doesn't change. We see also a dramatic change in the transferrin saturation. How does that reflect on endpoints? Looking at total heart failure hospitalizations, we see a 26% reduction in hospitalizations. And mind you, this is equivalent to many of the pillars of the standards of heart failure therapies that we have. Looking at the combined endpoint of death or hospitalization, again, we see a 20% reduction in events with just 2 or 3 shots of ferric carboxymaltose. So administration of ferric carboxymaltose in patients who have iron deficiency with ejection fraction less than 50 is something that can reduce heart failure hospitalizations. Looking at the quality of life, which means a lot to our patients more than what means to us. If you ask a patient, do you prefer to live longer or you prefer to live a healthier life, less sick, then the majority of patients would choose improving the quality of life over improving the quantity of life. And what the therapy did here is that there was a significant improvement in the Kansas cardiomyopathy questionnaire. The bigger the score, the better the functional class of the patient. We see a significant difference in all the parameters of the questionnaire. So how does that reflect into the guidelines? The latest ESC guidelines published last August, and among the workup, essential workup for patients with heart failure, of course, a proBNP, an ECG, an echo, a chest X-ray, a full blood count, and iron studies. They all get class 1. So whether he's an acute patient or a chronic patient, part of the routine labs that has to be done include an iron study, which is the transferrin saturation and ferritin. And all patients should be screened for anemia and iron deficiency with the blood count and the ferritin. And again, it gets, after these publications, intravenous iron replacement, specifically with ferric carboxymaltose, not with any other iron replacement, is recommended for patients with an ejection fraction less than 45 or 50, and with the criteria I mentioned, serum ferritin less than 100, or 100 to 300 with transferrin less than 20. And the aim is to improve the quality of life and to reduce the risk of heart failure hospitalizations, especially in patients who have been recently hospitalized with heart failure. This should be done pre-discharge and early post-discharge. So once the patient is hospitalized with acutely decompensated heart failure, we should give ferric carboxymaltose to prevent hospitalization and to improve the quality of life with a chance of maybe reducing heart failure mortality. So this is taken from the ESC guidelines. We have the 4 pillars of heart failure therapy: ARNI, beta blocker, MRA, SGLT2 inhibitors. We have volume overload for diuretics, and we have other therapies that we need to consider. And among these, iron deficiency treatment with ferric carboxymaltose is now class 2A. to prevent hospitalizations and to improve the functional class. The evidence that we have for other forms of iron therapy is much weaker, and mostly they don't work as ferric carboxymaltose works. That's why ferric carboxymaltose is mentioned by name by the guidelines. So to conclude, iron deficiency independent of anemia, regardless of hemoglobin, is associated with reduced exercise capacity, quality of life, all-cause mortality, risk of hospitalization. And we know that ferric carboxymaltose works to alleviate symptoms, improve the functional class, reduce hospitalizations, improving symptoms, especially in those patients who have been acutely hospitalized with heart failure. Thank you so much.